For those of you who don't know who I am, I'm John Parker. I'm one of the ITU consultants based at the LRI. I've been involved with a deteriorating patient in various ways over the past 20 odd years as the lead for critical care outreach services, a sepsis lead for about 8 years, and I worked with the medical director for about 3 years with a role around the deteriorating patient. So it's an issue that I've obviously been involved with quite a lot over that time, and things have changed a lot over that time too. It's obviously a really important subject for us. Deterioration obviously is the root of all of our unplanned ICU admissions. At the Royal, that constitutes about 75% of everyone. At Glenfield, I think it's about 35%, and much fewer at Leicester General. But it's still quite a big burden on our workload and takes up a lot of our time. So I think it's worth going through this subject, knowing what systems we have in place. And for those of you that are working in the intensive care and then are going off to work in wards or EDs, then this will be of particular relevance to you guys. So the sort of things I'm going to be talking about really are the sort of principles around how we should be looking at deterioration. And this has a structured framework which NHS England put together about 5 or 6 years ago, and breaks it down essentially into what's called the PIER structure, PIER, which stands for Prevention, Identification, Escalation and Response. And there are significant issues obviously around each of those elements that we'll go through, and there are various tools and tricks and things that we need to look at for those. If you guys were expecting within 45 minutes to know all there is to know about managing the deteriorating patient, I'm sorry, I'm gonna let you down on that one, I'm afraid. This is the framework for sort of how things should be viewed. So when we're thinking about deterioration, there's I guess there's a few things that we need to bear in mind. You can kind of envisage a deteriorating patient a bit like a boulder precariously perched on the top of a hill, which may or may not be about to roll down that hill and gather momentum. And if we don't stop that boulder rolling, then it's going to cause a catastrophe in some way, shape or form. And the sooner we get on and do it, then the easier it will be to prevent a bad situation evolving. So as I mentioned, there's the PIER structure to think about this. And the first one obviously is preventing deterioration in the first place, so essentially stopping the boulder moving at all. But then obviously there are situations when that isn't possible, and when it's not, we want to know as soon as possible that boulder's starting to move, to get people mobilized to go up and stop that boulder moving as soon as possible, because the more momentum it gains, the more difficult it's going to be. This is ultimately a team effort, requiring people from multiple specialties, multiple seniorities, and multiple disciplines to essentially work together, communicate well, respect each other to deliver the best for our patients. And without this, we are doomed to fail. So everything I'll say from now on is with the caveat that that is going to happen. Back to our boulder and this little schematic. Now, as you'll see in some of my slides, I have not corrected some of the AI generated spelling errors, so they're there for humour value. But essentially, a patient that's deteriorating, I guess the first thing is our boulder and how much mass it's got, how big it is, and that size of the boulder you can think of as the comorbidity. So this might be disease, severity of disease, or it might be to do with frailty, or particularly advanced age, as physiology gets detrimented quite badly from 70 years onwards. So a frail, severely diseased patient that's old is going to be a very large boulder, and a 25-year-old marathon runner who's completely fit and healthy will be the size of a tennis ball. So that's the first thing to bear in mind. And then whatever pathology is making them unwell, a ruptured aortic aneurysm will have a very high altitude, whereas the common cold will have a very low altitude. And then there's the incline, so that's the rapidity of deterioration. So the slope that the boulder rolls down, it could be very abrupt. For example, a ruptured aneurysm, stroke, or pulmonary embolus, they will obviously be very abrupt and very steep, whereas a chest infection or bowel obstruction or something to that will be much more gradual, but will be progressive. And then as our boulder starts to move, you can think about that in terms of the markers of deterioration starting to get worse. So an increasing new score, worsening AKI, those kind of things. And if we don't act on those, ultimately, as the boulder gathers more momentum, it's more difficult to stop and culminates in the patient dying. As I said earlier, the most important thing is to stop it moving in the first place, but if it does, then we need to stop it as high up that slope as we can. For patients that are very severely comorbid, even the slightest amount of movement, as you can see, will be very difficult to stop. And in those patients, it may be impossible to prevent, ultimately, the patient going into cardiac arrest. So going through the peer structure, let's talk about prevention. Okay, so sort of things that will be in place to a greater or lesser extent across the trust. System things, such as daily safety huddles, looking at the potential patients that could deteriorate and making plans in advance for those. Every patient that's admitted to hospital is supposed to have a consultant review within 14 hours of admission, where detailed plans are made and diagnoses and appropriate treatments are put together, and that will obviously help prevent deterioration. And then various tools, checklists, bundles, ward rounds, systematic ways of going through patients to make sure that there's no one that is going to deteriorate. Then there's patient-focused things that help prevent deterioration. The obvious example would be flu jabs, VTE prophylaxis, enoxaparin in preventing PEs, but then other things like infection prevention measures, hand hygiene, etc., to prevent hospital-acquired infections and patients getting ill from those. Anticoagulation is another example, for example, DOACs with patients with AF to prevent them having strokes. So these are all things that will prevent potential deterioration, and in some patients that may be all that's available to stop them deteriorating and dying. Preventing ICU readmission. So obviously this is much more close to our hearts as intensivists, and one of the things that we can do to help prevent deterioration is to think about the patients that we discharge towards, making sure that they're discharged in the safest way possible. So to that end, we went through a morbidity mortality process about 10 years ago now, where at LRI there was quite a high readmission rate, and readmissions are associated with a higher morbidity mortality. So preventing it is a good idea. And patients that were readmitted to ITU, back then there was about a 5% readmission rate. So that's about 60, 70 patients a year. Ideally, it should be close to 1%. Now, from that, we were able to pick up themes as to what was causing the patients to be readmitted as to what was driving the problems. And out of that, we developed a checklist called AIOU. Now, the one that you see in front of you now, I think is a proposed one, I think, going forward. Those of you that work on LRI ITU will have seen this, I'm sure, on the observation charts, and hopefully use it when you're thinking about discharging patients. But if I just quickly go through this, because it bases itself on checking that patients are fit for discharge, and there aren't things that are going to come back and bite those patients and get them back to ITU. So the first one is analgesia. This is particularly important for post-operative surgical patients, because those patients that are in pain don't mobilize, they don't deep breathe, they don't engage with physio, and they put themselves at risk of chest infections, VTE, venous thromboembolism, etc. So that's important to get on top of. The second one is early warning score. And so we always check the news 2 of patients before they're discharged. A score of 5 or more. Patients ideally shouldn't really be going to a ward with a score that high. So we want to know that they're physiologically reasonably stable before they go. A key component of this is delirium, new confusion, which will score 3 on in its own right. And discharging patients with that, we need to be very careful of. Interventions, investigations first. So obviously looking at things like hemoglobin, white cell count, U's and E's. We don't want to be sending patients with an evolving kidney injury or dropping hemoglobin or a new infection evolving. So we need to be checking those. Interventions is really about where the destination that you're sending patients to. Are they set up for things like parenteral nutrition, intensive physiotherapy, tracheostomy care? So they're the sort of things that we should be checking on. Organ support, so this could be as simple as someone needing a lot of oxygen. Anyone over 50% oxygen shouldn't be going to a ward, but recent stopping of vasopressors, inotropes, or people just off ventilators, you want a period of at least 12 hours before you know that they've safely broken free from those levels of support before sending them on. And this is AI, can't spell usual, but usual medication. So this is a new addition to our AIOU checklist on the basis of we've had a few cases where patients' usual medications, usually neuroactive ones like anti-Parkinsonian or myasthenic drugs, are not properly started before they leave the ward or leave ITU and go to a ward, and then develop problems directly because they've been omitted. So we should be getting through those, making sure that patients are suitable for discharge. Okay. So that's prevention. Identification. So identifying patients with deterioration. Over the past 20 years or so, various early warning scores have essentially evolved into a National Early Warning Score version 2, News 2, and that is now the basic currency throughout the NHS of detecting deteriorating patients, and is based essentially on a physiological track and trigger system that you see here. I'm not going to go through it in any depth, but I would encourage you guys to know what this says and be able to calculate a News 2 in your head if you can, because it's very useful when you're obviously going through things like AIOU, but also thinking about how unwell someone is when you visit them on a ward. It is validated. A lot of research has been done to show that it quite accurately predicts patients' risk of death. And it's important to mention that it's not risk of deterioration, it's risk of death. And someone, so for example, someone with a score in the teens, 13, 14, you won't expect to still see alive tomorrow. But it's set up where we start to get really worried from a score of about 5 onwards. Above 7, a lot of alerts go off on nerve center, and ICNARC expects anyone for escalation generally to be admitted to ITU if their score is 10 or more. between 5 and 10 obviously is dependent on obviously on more nuanced aspects of the patient. Okay, so News 2. If you don't know it, good idea to just start to memorize it. Obviously, the scores get higher as physiology gets worse. News 2 isn't perfect by any means, and in fact, it can be extremely misleading. And this is the first big message I think that I want to get across to everyone. We've set up a system in UHL and across the NHS that is entirely based on News 2 as the way to detect and identify patients with deterioration, and it's not perfect. Okay, as I say, it predicts the risk of death, but it doesn't predict the risk of deterioration, and at lower scores it can be extremely misleading in ways like oxygen score is binary, so there is no difference between somebody on 2 litres per minute of nasal cannula and someone on 100% CPAP. Obviously, these are very different in terms of how sick they are, and this became an extremely important issue through COVID. And NHS England released a lot of warnings and guidance around this, that we needed to monitor very carefully how much oxygen someone was on. And this is an independent predictor of if someone is unwell or not. So that's the first one. Next is there is a hypercapnic model for News 2, which essentially scores saturations to 88 to 92 as normal saturations, and anyone on lots of oxygen scores inappropriately. So if somebody doesn't have hypercapnic CO2 retention chronically and gets put on this model, their News score will be underscoring how sick they are. Okay, and I've seen plenty of examples where a patient is just hypoxic and doesn't have hypercapnic CO2 retention, and obviously their News 2 drops by about 3 points if it's used. So that's the next one. New confusion. So most of the elements, well, all of the elements of News 2 are objective. Their scores, their measurements, apart from the one assessing conscious level. So it's alert, new confusion, responding to voice, responding to pain, or unresponsive. And that new confusion actually requires quite a bit of work to detect it, and it can vary from one individual assessing it to the other. So you can often see it missed, and that immediately reduces somebody's EWS by 3. No account of treatment in progress. So classic example of this one, a patient could be in resus being aggressively resuscitated, blood or fluids being squeezed in hard, and the blood pressure looks okay, but as you know, as soon as that stops, the blood pressure is going to disappear. You know, this is a scoring system that doesn't take account of that, so you need to be mindful. And alongside that, really, young patients, we all know, can bleed out 25% of their blood volume and really not show that much in the way of physiology changes. They may get a bit of a tachycardia, and they'll be particularly shut down, and their veins may be less easy to get. And that is not part of News 2, as we'll see in a sec, but young patients particularly may compensate, and they have inappropriately low scores, but they might look terrible from the end of the bed. Other markers, so urine output, and this is particularly in surgical patients. Actually, this is a big issue. Fluid balance issues aren't necessarily manifest into nerve center, into News 2. Equally, pain doesn't. And as I mentioned, skin changes are not part of News 2. So severe mottling, a rash, pallor, cyanosis, or sweating doesn't register, although so patients can look terrible. They can be mottled and shut down, but that won't be registered within their News 2 score. As I mentioned, new confusion can be missed. So we should all do something called the SQUID, which is a single question to identify delirium. And we're supposed to ask families or carers of the patient, is their patient more confused than usual? Just that, that's it. So in other words, we find out from the nearest and dearest of the patient, is this their normal behavior or not? Okay, so this is particularly important, I think, for those patients that come in with a degree of chronic cognitive dysfunction. We want to know if that is more or less than usual. Okay, so that helps, I suppose, to a degree of reducing the problems we might have with new confusion being inaccurately measured within News 2. Not news. So important. So we collected some data over the past few years, and for unplanned emergency admissions to ICU in Leicester, about 30% of them have a News 2 less than 5. So wouldn't necessarily alert through the various systems that we have, and they come in for other reasons. Patient, family, and staff concern, as you're going to hear a bit more about this in a sec, but we should always be mindful of the patient or the family saying that he's not his normal self. I've got a sense of impending doom. All of those things should ring major alarm bells. Equally, if staff are concerned, then we should take those concerns seriously. Kidney injury has been shown to be an independent measure of deterioration, and that can often be missed. It's from blood tests that may only be done once a day, and they obviously live in a system that has to be looked at, and it's going to easily get missed when we're assessing a patient. I've got a clinical case to show you in a sec that illustrates that. As I said about COVID and oxygen, increasing levels of oxygen support, that should ring alarm bells that a patient's deteriorating. Serum lactate, now particularly in the ED environment, I think with this one, patients that come in unwell, have a lactate measured, get some resuscitation, that lactate should be repeated at several intervals because it's a really good predictor of if a patient's getting better and stabilizing or not. And a resistant high lactate should again ring alarm bells that something isn't going right. So patient family concern. One of the big changes that's happening now is something called Martha's Rule, which I know hopefully most of you have heard of. And this relates to a young girl called Martha Mills, who in 2021 fell off her bike and sustained a pancreatic injury and spent some time on a paediatric ward in a hospital. During that stay, unfortunately, she became unwell, really unwell, with sepsis. Her family said this is not a normal self. They're really concerned, and no action was taken about their concerns. And they raised these concerns on multiple occasions. She sadly died of her sepsis, and the coroner's ruling that her death could have been avoided if she'd been admitted to ICU sooner, and if the medical staff had listened to the families concerned. From this, there was a significant campaign from her family, and there has now been an initiative launched through NHS England around Martha's Rule. This started life as what we call a call for concern, which you may or may not have heard of, which has been running for a year or two now in UHL. But now everything associated with it across the whole of the NHS is called Martha's Rule. So what is it, and how does it affect us? Well, it's got three components. And the first one is that patients should be asked at least daily how they are feeling and if they are getting worse, or if they're getting better or getting worse. If they're getting worse, then there should be a structured response tool, a bit like News 2, that allows alerting to take place and the patient to be reviewed by an independent clinician. All staff should be able to ask for a review. This could be anyone, from HCAs to cleaners to junior resident doctors, consultants, whoever, anyone who's, if they're concerned about a patient and the response they get from the host team is deemed inadequate, then they can ask for a second opinion. And this second opinion can obviously be requested from the patient themselves, family of the patient, or carers. And where do these requests for a review go to? Well, the answer to that is critical care outreach services, or our DART team. And DART have been receiving calls regarding Martha's Rule for the, as I said, for the past year, and there's been hundreds of calls. A lot of them might be about car parking or the quality of the food or clinic appointments, but there have definitely been some that have been directly related to deterioration of patients that have been missed. I can give you a couple of examples. One patient was on the verge of committing suicide on a ward. Another, despite saying multiple times it was receiving the wrong dose of insulin, almost went into a hypoglycemic coma. And there's been at least one direct admission to ITU because of Martha's Rule. So it's here to stay, and it probably has a lot of merit that we continue to support. Now I'm going to just take you through a clinical case that occurred a couple of months ago in UHL at Leicester Royal Infirmary, and it relates to issues around identification of deterioration. So this patient is called a 75-year-old lady who was admitted with an acute abdomen through the accident and emergency department at the Royal, and was known to have diverticular disease. CT scan revealed a localized perf of the sigmoid diverticulum, and she was managed conservatively on the ward with antibiotics and fluids, etc. Was monitored. Plan in place was laparotomy if she deteriorated. From day one, really, her inflammatory markers understandably were elevated. CRP, I think, was about 200 and white cell count was over 20. U's and E's initially were normal, and initial EWS was between 0 and 1. And that's how things stayed for a couple of days. She then started to develop episodes of moderate to severe pain, and at times scoring 10 out of 10 with pain. You'll see what was happening with a blood test over those days in a sec, but essentially at day 6 on the ward, there was enough concern to repeat the CT, which showed an extensive perforation with widespread soiling of the peritoneum. She went for laparotomy and ended up on ICU. Now, just rolling back slightly, what I've charted there is this lady's serum creatinine at the top on the chart, and below sequentially the News 2 score done about twice a day. And I think what you can see here, if you just look at the News first, the first few days, News 2 is fairly it's unremarkable. It starts to creep up, and by sort of Friday the 5th, it's sort of holding around about 3 or 4. Okay, so something's changed, and that's associated with the increase in pain. But interestingly, that hasn't hit the magic number of 5, which you'll see later means a medical review, but it has gone up. So something has changed. What you see above, the serum creatinines that have been done, is that by Friday the 5th, you can see that the creatinine has gone from sort of 65, 80 to 203. and that constitutes an AKI3. It's interesting to point out that the plan to manage conservatively at this point carried on, and did so for the next 48 hours until Sunday, the 7th of December. As I say, when the CT scan was carried out, and then the patient went to theatre. So there was about a 48-hour period where there seemed to be some significant markers of deterioration, but no real change in management plan. So what happened to her? Well, she was admitted to the ICU, went rapidly into multi-organ failure on large doses of noradrenaline, was in anuric renal failure from the outset, requiring CVVH. And she grumbled on for a number of days. She had really bad surgical problems, requiring multiple trips to theatre, and really failed to progress. Had a large stroke, I think about 2 weeks into her stay, and really failed to thrive. And then, with agreement with family, treatment was withdrawn 23 days into her ICU stay. So I guess there's a couple of things that need to come out of this. The first is that I think this will be an M&M discussion between ourselves and the surgical team, but also there seems to be an opportunity, as I said, missed in terms of identification by way of acute kidney injury, but also pain, and also that EWS that was nudging up. It's easy to look back with, in hindsight, but an AKI3 out of nowhere seems to suggest that the patient was significantly deteriorating. The other message to get across here is that this kind of journey of conservative management of these types of patients is not uncommon now. And I think as a team, we need to be aware that our surgical colleagues do admit a lot of patients for initial conservative management, and give antibiotics for people with perforated diverticulae, appendicitis as well, and may not necessarily take these patients to theatre immediately. So we need to be mindful that there may be other markers of deterioration that we need to look out for and spot, and maybe move these patients to theatre sooner than they are. Changes in modelling. Now, whenever you conduct an assessment of a patient, I think it's absolutely vital to look, obviously, at peripheral perfusion. The new sepsis guidance that came out from NICE it's about a year and a half ago now, puts mottling extremely high up in how you assess patients for high-risk sepsis. And the presence of mottling will immediately bump the patient from one category to another, so from low risk to intermediate, or from intermediate to high risk. So it's essential that you look out for it. As you see, usually the best place to find it is usually on the leg, around the knee, and it tends to spread out from the knee down the shins and up the thigh. As you can see, it can be graded from grade 1 to grade 5, where 1 is just around the kneecap and 5 is occupying the whole leg and up onto the abdomen. Now, predicted mortality with just having mottling around the knee can have an up to 50% mortality. I mean, that's grade 1 to 2 mottling. Grade 5 mottling has a 90 to 100% mortality. So it's absolutely vital that we look out for this. So any patient that we see, we should be looking for this. So moving on from identification to escalation now. So this chart that you're seeing now is fairly self-explanatory, but it's the escalation plan based on news. Okay, so I've already said news is a load of rubbish, but this is what plans are in position, and you should probably overlay things like AKI similarly, so an AKI3 would be in the red, but as you hear, also get alerted to AKI2s. But essentially, once the score gets to 5, there should be an immediate medical review of a patient on the ward, and above 7, a senior medical review and a DART review with consideration for escalation of the patient to HDU. So escalation alerts. So our critical care outreach service, or DART, Deteriorating Adult Response Team, receive automated alerts via Nerve Centre, and they receive them from in these ways. So anyone scoring more than 7, they'll get an automated alert. Acute kidney injury 2s, sepsis alerts we used to get. With changes in the alerting system, and currently they don't. As I said, they get calls. They have a direct phone line that concerned patients and families can phone them directly relating to Martha's Rule. Any concerned staff obviously can contact them by phone or bleep. And then as a link in another direction, we have DartMed, which is essentially a daily meeting with a consultant consultant in intensive care who may also know about other patients who are deteriorating that have not come onto DART's radar, and direct them accordingly. So there are various sources of how escalation happens, but the centerpiece of escalation on a deteriorating patient in UHL, including ED, is via the DART service, who obviously we work very closely with, and they will often be in touch with us about patients they're concerned about. So I'm getting towards the end now, and I just wanted to just sort of float by you the concepts of response, particularly when we're talking about critical care. So what I want to say first is that there are no hard lines on this chart. Although it's color-coded, they're color-coded, and the lines are there really for explanation, but they are grey zones. Okay, so I want you to, first of all, when we get referred a deteriorating patient, they will have a background of some kind of level of comorbidity. And we can really break this down into mild, moderate, or severe. This could be for frailty, it could be disease comorbidity, severe functional limitation, it could be extreme age, as I mentioned earlier. So mild frailty score, you're talking up to 4 maybe, moderate 5 to 6, severe sort of 6, 7, 8, 9. So we can categorize patients in that way, but not in a hard categorical way, obviously. And then they will deteriorate. And that, as I said, could either be advancing news score, it could be acute kidney injury, a concern, oxygen requirement, severe pain, etc., etc. So they could be getting worse from their baseline, and then we get referred them when they become really sick. So I'm going to look at each of these categories and talk about what we'll be doing with them. First of all, on the mild, so these are generally pretty fit, healthy people normally that are starting maybe to deteriorate. Obviously, when they're not deteriorating, we expect this sort of regular monitoring to take place. As I said earlier, do not overly rely on news 2, particularly in young, fit people who may be bleeding out and no one's noticed. Although respect may not be high on the agenda, every patient that's an inpatient should ideally have a respect conversation. Prevention obviously is really important to prevent deterioration, things like VTE, HAIs, etc. But that's a sort of normal day-to-day business of what you'd expect in hospital. If they deteriorate, patients that are clearly got minimal comorbidity and are becoming unwell, we should be thinking aggressively about bringing them as soon as we can. So this should be the minimum amount of debate, discussion. There should be an intention to escalate this patient into the right place as soon as possible without delay. So on the other end of the scale, patients with severe comorbidities, what you'd expect when these patients are admitted to hospital is that there should be preemptive conversations about the futility of aggressive care, that respect conversations and the appropriate paperwork are completed. There may even be preemptive conversations with palliative care, because people with severe comorbidities, if they become unwell, then they are not likely to survive. And as I said right at the start, this is the group of patients particularly where prevention of deterioration is really important. So them getting all their vaccines, making sure that they're getting, you know, their DOAC for their AF, making sure that they don't pick up hospital-acquired infections by good infection control measures within the hospital. Now, all of those things should be particularly important for this group. And then when they do deteriorate, the team looking after those patients should then start to roll forward you know, the process of end-of-life care, focusing on comfort, stopping unnecessary interventions, and involving palliative care as they need. And it's not really for critical care to be involved with these types of patients. And then there's the difficult group in the middle with moderate comorbidities. So when they're admitted, I think it's really important to get complete clarity on the functional state and disease processes within these. And this often requires conversations with patient and family. And this should be done by those patients, those staff admitting the patients to wards. And then what naturally flows on from those conversations will be elements of respect conversation. Again, prevention of deterioration is really, really important for this group. And if they do deteriorate, then there should probably be an early conversation between senior members of the referring team and senior members of the critical care team to outline a plan about what to do as things get worse, and then to enact that plan and monitor how it goes. So this is a sort of a grey zone of what to do with these patients, but that requires probably senior level conversations about how to escalate. So I'm going to wrap up now and say that deterioration, the best way to think about it is around prevention, identification, escalation, and response. As I just said, prevention of deterioration may be the only available strategy for certain patients, particularly with those with advanced frailty and severe comorbidity. News-based identification of patients is prone to flaws, and lots of them. And other things like acute kidney injury, oxygen requirement, pain, skin changes are all really important. The introduction of Martha's Rule, which is set to be fully rolled out by about April this year. So you'll be seeing more and more of this in the coming months. So rollout of Martha's Rule, it's going to enable anyone to contact DART, which they are already doing. And that's going to be an important line of potential escalation. Skin changes are a vital part of our clinical assessment of deteriorating patient. Escalation is a team-based process, said right at the start, you know, that whole process of treating a deteriorating patient, but then moving them through and deciding whether or not they are for palliative care or for escalation to ITU does require a lot of forethought and planning. The response that we do should be tailored to the characteristics of each individual patient. So although I characterized by compartmentalize these patients, they are very individual. So for example, quite a frail elderly patient who's got an acute abdomen may end up having a laparotomy if, for example, we know it's due to a band adhesion, which is easily treatable. On the other side of the coin, a very severe pathology like a perforated cancer may not. So these kind of things do require tailoring and discussion.
No
Go ahead.
Questions? No questions.
Thank you.
Thank you.
Yeah, thanks very much. Thank you.
Hello everyone, my name is Anna. I'm one of the emergency medicine ST2s currently in Leicester Royal Infirmary ITU. So today I'm going to be talking about the IMMUNO-SEP trial, which was published last month. So we do get a lot of patients with sepsis in ITU, and the new sepsis 3 definition also says that it is organ dysfunction due to dysregulated immune response to an infection. So, and the new advance with sepsis has been tackling that dysregulated immune response. And so this study was published in last month, looking at whether targeted immunotherapy can have benefit when it comes to patients with sepsis. So previously there have been other randomized control trials, but what they did was they used a blanket approach when it came to using immunotherapy in patients. So they would use medications to suppress the immunity in all patients with sepsis, for instance. And those RCTs did not prove a benefit and hence were not used in practice. And we have had other studies which have shown that the immune response when it comes to sepsis is a spectrum. And there are patients on either end of the spectrum. You have patients with a hyperinflammatory response and patients with a hypoinflammatory or an immunoparalytic response. And it has been proven that these two sets of patients are the ones with the worst prognosis when it comes to sepsis outcomes. So the conditions we're looking at with this study is, first one is the macrophage activation-like syndrome. We'd have heard of HLH. So this is something very similar to that, but induced by sepsis. And so here what happens is the main pathology itself, excessive production of interleukin-1, so excessive activation of macrophages, leading to organ dysfunction. It can lead to destruction of red blood cells and DIC. On the other end of the spectrum, you've got patients with sepsis-induced immunoparalysis. So these patients, the immune cells are pretty exhausted. So sometimes these patients often would have had an initial hyperinflammatory response, and the immune system becomes quite tired and exhausted after this, and they have a hypoinflammatory response after that. So this randomized control trial was a phase 2B clinical trial in that it was looking at the efficacy of these drugs when it comes to these two conditions to see if there was any improvement in organ function with these interventions. And this was conducted in 6 different countries in Europe. Given that it's a phase 2B study, they had a very specific population that they studied %. So it was ICU patients with sepsis, as defined by the sepsis 3 definition. And they looked at very specific diagnoses. So it was community-acquired pneumonia, hospital-acquired pneumonia, ventilator-associated pneumonia, or primary bacteremia, which is where you can't find the primary source of sepsis. And also they had to fulfill the, criteria for diagnosis of either macrophage activation-like syndrome. So the main parameter they used for this was a ferritin cutoff more than 4,120. So we've had multiple studies in the past which have shown that this ferritin cutoff is associated with a very high specificity and high negative predictive value when it comes to macrophage activation-like syndrome. So it has good data supporting it. And for immunoparalysis, what they used was HLA-DR of less than 5,000 per cell. So there have been few studies that have reported this cutoff, but again, it doesn't have as much of a data backing as the ferritin. And the exclusion criteria that they used was, the first one is abdominal infection, because these patients often require source control to the treatment. UTI patients, because they often have a good prognosis when it comes to sepsis. COVID patients in the absence of MLS, because their immune response tends to be quite complex. And also it had to be, the intervention had to be given within 72 hours from the onset of sepsis. But again, the onset of sepsis can be quite arbitrary, so that can be a bit of a difficult one to know. So the intervention that they used for MALS group, what they used was anakinra, which targets the interleukin-1, which is one of the main pathologic features in MALS. And in the other group, which is the immunoparalysis group, what they used is interferon gamma. So interferon gamma helps in boosting the innate immunity. It also improves antigen presentation. So these two target the key pathologies in both these. So these are good interventions with respect to that. And these were compared with placebo group, where they used normal saline as the control. And the outcome was they were looking at improvement in the organ function. So they measured it as SOFA score improvement by day 9. And this study was randomization was done with a computer-generated sequencing. They divided it into equal number of patients were set into both groups of control as well as intervention. And later on, when they looked back on the data, patients that they had randomized into the study, the baseline characteristics of the patients were comparable, which is a strength for the study. So this is the patients that they have randomized into the study, and you can see that all the patients were accounted for. So they screened around 672 patients, and over half of those patients were excluded because most patients fall into that intermediate category, which is not MALS and not immunoparalysis. And the number of patients, the sample size of 280 was calculated. So this was based on an assumption that with the intervention, there would be a 20% improvement as compared to control. And again, you can see that not many patients have dropped out of the study, which is also a supporting factor for the strength of the study. Now, this study was a double-blinded and a double dummy study. What they did is, once they screened the patients, they would take a blood sample from them and would send it off to the central lab. And there they would test the blood sample for ferritin and HLA-DR. And the patients would be then, if they fulfilled the criteria for either of these two different pathologies, they would be randomized into intervention group or control group. Then there would be pharmacists who were unblinded to this. So these pharmacists would pack the drugs. So for intervention group, let's say for MALS group, the macrophage activation-like syndrome group, they would be packing an intravenous injection of anakinra and a subcutaneous injection of normal saline and sent to that group. Patients who have immunoparalysis, it would be intravenous saline and subcutaneous interferon gamma. And the patients who were in the control group would receive both intravenous and subcutaneous saline. So, and all these drugs look the same. And when they were sent off to, so all the patients, the investigators and the clinicians were blinded to what intervention was being received. And the only thing is the clinicians with the routine bloods, they might have been able to tell which immunophenotype the patients fell in, but they wouldn't be able to still be able to tell what intervention or control they received. The primary outcome that they calculated was more than or equal to 1.4 point decrease in the mean SOFA score by day 9. So what they how they measured this is, so they took a mean of the SOFA score from days 2 to 9, and they subtracted this number from the SOFA score of day 1. So this is what they measured. So this cutoff again is from previous studies that have shown that this 1.4 cutoff is associated with a 28-day mortality benefit. So you can say that 35.1% of patients in intervention group have achieved this compared to only 17.9% in placebo. And this is also, again, statistically quite significant. They did a couple of further tests to make sure that this result was significant. So they did a confirmatory model, which adjusted to the initial sepsis severity. So in that as well, we saw that the odds of patients who received the intervention improving the organ function was much greater. They did another sensitivity analysis. What they initially did was, if the patient got discharged before 9 days, for instance, they would carry on the same SOFA score for the rest of the days until day 9. With the sensitivity analysis, they excluded those patients and checked the data again. Again, it was consistent, which shows that the primary outcome was quite strong. Now, there were a few secondary outcomes that they looked at. One was looking at the SOFA reduction in both groups separately, MALS group and immunoparalysis group separately. Again, there was improvement with intervention, and that was also statistically significant. The other thing they looked at was mortality. Now, the important thing is that this study was not powered for mortality, was not powered enough to detect an improvement in mortality. So with 28-day mortality, there was a slight improvement in intervention group, but that was not statistically significant. And 90-day mortality, interestingly, the control group had lower mortality, but again, that's not statistically significant either. The next thing they looked at was whether there was the SOVA reduction by day 15 to see whether there was whether this response was just transient or whether this was maintained. So again, it showed that there was an improvement with the intervention, and that was also again statistically but significant with a p of 0.004. The next one was reversal of the sepsis-induced immune dysfunction by day 28. That was again significantly higher in the intervention group, and that was statistically significant. And the last one they looked at was on the day 15, whether there was any worsening of the infection, the underlying infection. So patients who received the interventions had lower chances of that happening. So that was also, again, statistically quite significant. And looking at the adverse events, out of a total of 1,069 serious adverse events with the study, only 13 were likely to be probable or possible to be relating to the, and also out of that, 9 related to the intervention drug and 4 related to the placebo. So again, this is not a big number, so it is quite acceptable. With anakinra, the main one that we have seen was anemia, and with interferon gamma, it was hemorrhage. So they did some post-hoc analysis with the data that they collected. So one of them was the time taken for the reversal of the sepsis-induced immune dysfunction. This was shorter in the intervention arm. They again adjusted the data to look at patients who had Charleston comorbidity index of more than or equal to 5 and patients with a baseline SOFA score more than or equal to 10. These patients specifically had greater odds of achieving the primary endpoint. And they also had greater reduction in the 28-day mortality as compared to placebo group. So the positives of this study are that the research question has done quite well. The outcome is very well defined. They had a good retention of participants. The blinding and randomization were done quite well. So the blinding was pretty solid, and the randomization, again, when we checked the baseline characteristics of the patients, it was comparable. They were able to demonstrate a statistically significant difference in the primary endpoint. There were a few limitations in that, again, it's a phase 2b study, so we need to keep that in mind. But again, mortality benefit was not proven because we used a surrogate marker here. And again, the primary endpoint was a means of a reduction. So there can be some issues like, what if the patient infection was not too severe on day 1 and became worse on day 2 or day 3? That again wouldn't really show a big benefit. So there are some limitations with the mean SOFA calculation itself. And again, what this used was a single time point immunophenotyping. So when the patients were initially screened within 72 hours, that was when the blood test was done. But again, we know that sometimes the patients can have an evolving immune phenotype. So initially they might have hyperinflammatory response, which can get exhausted as the time goes on. So whether there's any benefit to testing further and targeting with the blood results according to that, we're not exactly sure. So here I'm comparing it with another study. So PROVIDE study was conducted in 2022. There's a lot of data from PROVIDE study was used in conducting this IMMUNO-SEP trial. So the main aim of PROVIDE study was to look at patients, the immunophenotypes of patients who had sepsis, and to see how it affected mortality in these patients. So that's how they proved that patients with MALS and patients with immunoparalysis had worse outcomes, more mortality as compared to patients in the intermediate group. They also did a very small trial. Few patients received anakinra, 2 patients received interferon gamma. So there was some efficacy proven with anakinra, but again, it wasn't a big population that they tried it on. And in conclusion, you can see that the sepsis immune response is quite heterogeneous. So using as one-size-fits-all kind of immunotherapy doesn't work. So this study has shown that a phenotype-guided therapy can improve organ dysfunction based on the study. Survival benefit is yet to be studied. So we need further studies to see what the survival benefit is before we can implement it into the clinical practice. Has anyone got any questions? Anything?
I've got a little, it feels very neat. So in terms of the numbers for the eligible patients,
Yeah.
did the author say what proportion of males immunoparesis versus those who have got bog standard intermediate?
Yeah. So I showed
So
you.
my old eye is not cashed
Yeah.
up.
Right. So there's I'll have to calculate it in my head, but that's all right. 672 patients were screened.
Yeah.
So 355 had unclassified, which is more than half of it. But I'd say around 55%
Okay.
or so had the unclassified.
Okay.
That's great. Any other questions at all?
Really good. Thank you very much. Just gonna get my code.
Hello.
Let's stop sharing. 1 second. Stop sharing.
Yeah, just an observation, really. I think, I think we're moving away from the one-size-fits-all strategy. We've known for a long time that sepsis obviously is a heterogeneous disease. I mean, it's interesting reading between the lines in some of that data. You'd think that if you looked at receiver operator curves, that they converge probably somewhere between 30 and 90 days. And it might well be that you get some short-term benefit with this treatment.
Okay.
That isn't long lasting. And I guess the only way, and it's with all these things, single center studies, obviously the next step is for it to go multi-center and much larger piece of work, which I assume is what will be needed. And we've had promising pieces of work on sepsis like this many times from single centers. I can think of things like vitamin C. I can think of things like activated protein C. I can think about all sorts of things that haven't stood the test of large scale studies. And until that's done, I suspect that it would be difficult for us to I assume the investigations and treatment that we're talking about here, particularly investigations, would be quite costly. And if it doesn't really ultimately convey any benefit to our patients, then I'll be struggling to think it's going to come into our practice anytime soon. But I guess everyone will be looking for that large-scale study to give us the answer as to whether it actually gives outcome benefit.